Okay, so this is the setup I've got. This arm here you see was designed for a monitor so the patient can see the screen when you've got an intraoral camera. Okay, so I didn't want that. I wanted a Mayo table like this. And this is Eldo's Mayo table, which he only uses when I come to visit him. Is that right, Eldo?
Not at all.
You are actually using it?
Yes, for all implant surgeries we use this.
Good, okay. I think these are fairly standard equipment in supply companies. It should be fairly easy to find. What was the shop that you got it from, Eldo?
This is from Kerala Surgicals, and this is supplied by Godrej. Manufactured by Godrej.
Can I ask you something?
Yeah.
The wheels in the bottom, if you see,
Yeah,
they're a hindrance, right? They won't allow the stable to go over the patient.
it depends upon the kind of chair. We have tried it. Yeah, this is in one chair. One room we have tried. So it can go onto the patient's chest. Depends upon the base of the chair.
Tejas, you have to seat the patient, lie them flat, and then bring this over them.
Got it.
Okay. It's a little awkward, but it's better than not having. It's beautiful having the instruments exactly where you want them. Okay.
I think confident and all will be difficult, right? Confident.
Say it again.
Yeah. I should try on. I have a confident chair. I'll try with confident and let you.
What was that comment?
There's a confident chair. Ashwin wanted to see whether this goes over a confident chair. So I have a confident chair. I'll try this tomorrow and let you know.
Okay. So here's Christine setting up the table, getting all the instruments in the right place. She's holding the sterilized implant motor. You'll be glad to know. You haven't
You used to tell me of some way to arrange this. The nearest one should be the one that is something like that.
In the order of use.
Yeah, order.
In the order it is going to be used.
So he had some specified thing for that.
When this, oh, just wait 1 second. Just watch this a minute. Now, when you look at this, you see the two instrument trays nearest to the dentist and the chairside assistant. Those two trays have things like the just 1 second. They have the scalpel, the needle holders, the periosteal elevator, the basic instruments along the front. Okay, the other instruments are nearer the back. But that doesn't matter because the dentist and the chairside assistant are not going to pick up instruments. surgical assistant is going to do that. The dentist should be doing the dentistry. The assistant should be assisting the dentist, retracting and aspirating. Do you work with a surgical assistant, Eldo?
Yes.
You do? Okay. So, using a pre-packed disposable Mayo table covers, okay? What I'm showing you here is the way we would be doing it, and you have to decide how you adapt this to the way you do things. You see the way she's opening this up? This would be on your table, Eldo, at the side of the treatment room, where you have your instruments ready. Okay. So now the Mayo table cover is ready to be put onto the Mayo table. Now this Mayo table cover should not touch the patient's, the assistant's gown, or should not fall on the floor. Okay. Now, I wonder, though, if you practice this, what we're showing you now. The purpose of passing back to back is to avoid compromising the chain of asepsis by contaminating the gowns of the gown people. Okay. Everybody should be kept at least 2 feet away from the gown people, if possible. And the gown person, when they want to move from one place to another in the treatment room, should say coming through, and then they pass back to back with the other people in the room. And the roving assistant there should keep away from the Mayo table by at least a foot. And everybody should be watching so that they don't touch the Mayo table cover. Okay. One thing, Tejas, is Tejas still with us? Yeah.
Yes, I'm here.
Yeah. One thing I haven't done is, if you could imagine, on the left of this treatment room is a long table where we set everything up ready. And on the extreme right of it is the Mayo table cover. And then this instrument pack here, and then all the other instruments in a logical order. Unfortunately, I don't have a photograph of that explaining that. And at the present moment, there's so much junk on that table that I can't photograph that, but I do intend to at some point. So before what you see here, the roving assistant has brought in all the instruments in a washing basket, including the Mayo table cover and the patient drape. All the stuff that we need is brought in and put out on that table in order. Okay.
Okay.
So then we're proceeding to open this. Now this is double wrapped. The important thing is that the roving assistant does not touch the inside bagged item. Now, just watch this for a minute. The assistant is not going to take the instrument tray. Actually, Eldo, watch this. When the roving assistant passes it to the gowned person, the gowned person stays like that until the roving assistant presents the tray to the assistant. You just watch this now. So she stays still, then he does this. Okay. Do your assistants do that, Eldo?
No.
Okay, make a note. You have to teach them how to present. Okay.
Yes, sir.
Now, if the surgical assistant grabs that tray, there is always a risk involved. One of which is that she contaminates her gloves. Okay. So this is an empty tray. We used to put the instruments that go onto this tray on the tray, but by the time they'd been sterilized and put on the shelf ready, by the time they came out, they were in a shambles anyway. So it's easier to have, and we use 2 empty trays like this. By the way, he should have that tray further away from his chest. Okay, he shouldn't have it close to his chest. So these are the instruments that are going to go onto those trays. They are, these are the needle holders, the scalpel handles. Included in that is a scalpel blade in its cover. Do you have that in that bag, Elder?
Yes.
Yeah, okay. They don't need to then find a scalpel blade and put it onto the aseptic table. We've seen this a bit. This is the implant kit with the drills and the ratchets and things like that. And these are in the gusseted type bags. These are the expansion instruments. Aldo, are you using any sedation yet?
No,
Why is that?
I'm afraid that itself will cause some problem, some heart, some bradycardia or something like that. It's always in my mind.
So, what is the incidence of bradycardia with patients who take a sleeping pill at night?
I don't know. Should I get a physician's consent for that before I prescribe diazepam 5 or diazepam 10 mg? Or
The problem with
Um,
diazepam is it used to they used to assume that it causes bradycardia. That's why now alprazolam is preferred. It does not cause bradycardia.
okay,
So you can give your patient Alprax 0.25 mg about an hour and a half before surgery.
okay,
why an hour and
So
a
with
half?
diazepam, because that's when it reaches the peak blood level to sedate the patient.
I would suggest an hour because it's going to take 15, 20 minutes to get everything set up in the treatment room.
Okay.
Okay. If he was giving, say, would you say take just 20 milligrams of Valium? If he was, that would be given, say, half an hour beforehand.
Okay.
Have you checked out temazepam, Eldo?
Tonazepam is not available. I've checked it here.
Yeah.
So, but diazepam and Alprax is very easily available.
Okay. So, okay. Now, what I would suggest you do, Eldo, and Tejas, you can advise him on this, is you have a suitable patient and you get permission, you get them to sign the consent forms, okay? And they mustn't drive a car or do any financial dealings or cooking or looking after children, okay? And you choose a patient and you give them a low dose.
Yeah.
Okay. And then as you get more confident, you give them a higher dose.
Okay.
Okay. And you'll find that it's much more relaxing for you if the patient's relaxed.
Yes.
Okay. But I would also consider getting an anesthetist in to give midazolam intravenously.
If that was in India, it would have been so nice.
You can always give nitrous oxide.
Okay.
So what intravenous drug is used in India?
Ketamine and midazolam is used, but for that you need an anesthetist.
Okay, so you get one in. Okay. I did all my cases, virtually every case, with somebody giving sedation.
Exactly, because the cost will marginally go up. Here, the cost will go up astronomically if I get an anesthetist.
Why astronomically?
Say you have a 2-hour procedure, okay? The anesthetist will charge you by the hour. The first hour is 5,000 something, and then every hour it's about 2,500. That's the anesthetist charge. Then there's medication. Then there's recovery.
Oh, I didn't know it's 5,000.
And when the patient is in recovery, again, the anesthetist will charge you at that time to monitor the patient post-op for about an hour.
Okay.
So you have to factor in all those costs as well if you're looking at IV and sedatives. Nitrous oxide is cheaper that way. You don't have to have an anesthetist. It's probably a setup cost, a one-time setup fee.
I have a little bit of a suspicion, Tejas, that you were deciding for the patient.
I am.
Exactly.
I
So the-
agree. I am. I'm
so
telling
the-
you what will happen if I tell the patient that his implant procedure will cost say 12,000 rupees extra because an anesthetist has to be called in.
And the patient's arrived in his BMW.
Those are the bastards who bargain.
That's an assumption as well.
No, by experience. Not an assumption. Ask Deepthi.
Hmm.
I second him.
Eldo, I would investigate oral sedation to start with, okay?
Okay.
But I mean, how are you going to use your ridge expanders malleting on patients without sedation?
That is true. You're right. It's terrible.
Yeah. Okay. So I was using temazepam, about 30 milligrams. But you have to find out what is. I mean, you're using drugs that are used as sleeping pills.
Yes.
You're not getting into general anesthesia.
Yeah.
Okay.
Well and good.
But take this again. I think if you say, would you like to have something which will make you feel comfortable and calm? If you ask all your patients that, some of them will say, yes, please. Okay. And if somebody, you say, well, we can even give you, have an anesthetist to give you some sedation, which is really very good. And it would you be interested in that? You know, and let the patient choose. Anyway, going back to where we were.
Okay, while on this topic, I just want to ask you. Say you call in an anesthetist and you're doing IV sedation. Besides your emergency kit, would you require anything else?
Besides
safety?
what? Sorry?
Your emergency kit. What sort of emergencies would you need to be prepared for in addition to your general emergencies?
The person doing the sedation would bring what they needed.
Oh, okay.
Okay. You do need a pulse oximeter.
That's it.
Yep.
In terms of emergency management, say something goes wrong in the anesthesia.
if you were in Eldo's practice and you had a cardiac arrest, he would be able to produce oxygen for you immediately and start cardiac resuscitation, and then you get the medics, the paramedics in.
Is it the most common complication is slipping deeper into sedation or respiratory depression? So intubation and ambu bag is necessary, I think, for sedation. If the patient has some respiratory
Yes. Yes.
You need an ambu bag, yes. I don't think that we should be intubating patients.
No, not we, the anesthetist.
Yeah.
They are well.
So they would bring what's necessary.
They
Okay.
don't in India. You have to give it to them. That's where the cost goes up. And it's not a blocker.
That is a blocker, definitely. Talking cost and expensive and things like that, you know. I was with a friend of mine last night, and you should see the cases he does, implantology-wise. They absolutely blow my mind when I see what he does. And he does it all under sedation, and he gives the sedation.
Oh.
Okay. I just think you can't do implantology to a high standard without using sedation.
Okay. What about nitrous oxide, Stuart?
I never liked it, personally. I've had that stuff. Have you breathed it much?
Yes.
I would personally stick to Glenmorangie.
Okay.
Okay, people use it, okay. Do you use nitrous oxide?
Yes.
And fine, okay, that's one alternative. And you're successful with it?
Yes.
Yeah, okay, that's another
What is the
alternative.
cost of setting it up? What is the
Sorry,
cost of setting it up? Nitrous oxide in the clinic.
You got a wide range, as cheap as 60,000, as expensive as 4 lakhs. So it's a big range. You have a couple of different brands available. I can talk to you offline on this.
Saline, can you ask a different question? What is the investment outlay?
Okay. Yes.
Okay. I think that slow drilling technique, Eldo, have you started doing that?
Yes, I'm always doing it now.
Yeah, okay. Because every time we used to open up that sterile tubing was about $5.
Yes.
Now, who is being a cheap bastard?
Well, the problem was, Tejas, often we would do the whole procedure with expansion instruments and it would never be used. You know, that irks me, okay, when it's unnecessary.
I have a tube which is autoclavable. I got it with the implant motor. I heard the discussion last time on recording.
So,
They claim it's autoclavable.
yeah. Are you using slow drilling, Saline?
I have no patience.
Sorry?
I wish I can. I have no patience. No implant. I've
But
heard
you
of flow drilling, but I haven't. I would try it.
Have you seen that video I sent?
No. I just went through the discussion in the last section. I'll see the video.
You've got the video I sent you.
Yes, but I haven't seen it. I'll see
Okay,
it.
have a look at it because you'll save all that trouble of using Saline and all that. Okay. Now this is a very expensive tin foil. These two lights are on a special track in the ceiling. Now this is, you have to adapt this to the way you work, okay? I'm presuming you're going to be using plastic throwaway syringes. Do you ever use cartridges of local anesthetic? Tejas,
Yes,
you do?
yes, from Septodont,
Right,
but not the in-safe syringe.
no. And you use these when you're using aseptic technique? Yes?
Say that again.
You're using these cartridges when you're doing aseptic technique?
When I'm doing routine general dentistry also, I use them sometimes.
Yeah,
Patient
but,
is willing to pay for it, yes.
yes, but you do use them when you're using aseptic technique?
Yes,
Okay. Did you see the way we handled the cartridge just then?
can you just show that to me?
How do you get it from the packet onto the aseptic table?
I think the asepsis breaks there.
Yes, okay, so if you watch this, just 1 second. He's wiping it with an alcohol wipe. Okay, because in the packet it's not sterile. If they sterilize them, it alters the adrenaline.
Yes,
So the only way of doing it is to wipe them. Some people put them into cold sterilization liquid.
the rubber,
Sorry?
the rubber, the rubber plunger, it reacts with the the cold sterilization liquid.
The other thing is that the liquid in the cartridge is under negative pressure. And when you put it into the sterilizing liquid, it sucks in the sterilizing liquid into the liquid, the local anesthetic. Okay, and results in pain, post-operative pain.
I
Okay,
can imagine. Okay.
yeah.
So that's why these are auto aspirating, because of the negative pressure.
I think that's a separate thing. It might be. I don't know. Okay. So don't put them in sterile. Oh, the other, we only put them in for a short while, people say. Eldo?
Yes, I'm noting.
Okay. So they put 6 cartridges into the cold sterilization and 4 of them are used. What happened to the other 2?
That will be replaced by cold sterilization liquid.
No, they stay there until 3 days later when they're then used.
Yes.
Okay. You see, as I say to you frequently, either everything's important or nothing's important. Every little detail is important, okay? That's the gauze, which has been sterilized in the tray, in the bag. Yes.
Do you arrange all these instruments? Do you set up all these instruments every time, or do you plan ahead what instruments would be required for a particular surgery and then only keep those in?
Okay. The roving assistant or the surgical assistant prints off the surgical assistant duties. In that is a list of all the different instruments needed for different procedures. And somebody ticks off which is needed. Okay. You might, with inexperienced staff, do the ticking off on that list. Okay. So specifically, this setup is for placement of implants. So we've got the expansion instruments, we've got the implant kit on the left there with the drills and the ratchets and all that's needed for putting the implant in. So specifically, yes. Okay. But there are set bags of instruments. Have you seen those lists, Tejas? Okay.
Yes.
Yeah. Okay, so on the tray, in one of the bags is a scalpel handle and the scalpel blade. Okay. So she's now putting the scalpel blade on, and she takes a pair of needle holders to push it on a little bit further. That's the tongue-in-cheek retractors. Three different sizes. So this is setting up the implant motor. Ashwin, the first thing you have to do is to dust yours, okay? This is to hang the saline bag, which we're not going to use. But when you're doing sinus grafting, although you need to use the water spray,
Yeah.
the saline spray.
I personally, even though I do slow drilling, I just, drip a little bit of saline onto it, not fully, dry.
Is that because you can go to church on Sunday and feel better? If you go to confessional, you can say, I do drip saline on.
That is combining old and new concepts.
Yes. Maybe in 5 years' time you won't do that. So you don't sterilize your motors, Eldo?
No.
What, you put a sterile sleeve on, do you?
Yes.
So Eldo, you or your surgical assistant or chairside assistant would be holding the tube. And the roving assistant would push it into one end. And then they'd filter it through.
Yes.
Right.
I have a green cloth with Velcro on it. So
You're muted.
yeah, so I have a green cloth with Velcro. So you simply fold it over the tubing. You don't have to thread it through the sleeve.
And do you put an elastic band around it? Or
Yes.
how do you do? Where the motor is?
Yes.
Yeah, okay.
But still it slips off. That's a problem.
Say it again?
It still slips off.
Not if you tie it, if you secure it. Like the end of it has a small rope kind of it stitched into the cloth.
Okay.
You just have to tie it tightly.
How
Like
do
how
you
you have the gowns.
How do you secure yours, Eldo?
The same way we have a tie on that, but still during use the tie, it's not the tie becomes loose, but it slides over the motor because it's so smooth. It slides over it.
Why don't you have an elastic band in there and you put the elastic band around several times?
Okay, I'll try that.
Eldo is writing that down on a post-it.
Yes.
That is similar to when you say something to a member of staff, can you do such and such? And she's not going to do it immediately. If she writes a post-it and puts it in her pocket, It gives you confidence that it might be done.
Okay.
We're assuming, Tejas, we're going to do a sinus graft, so we need the saline this time.
All right.
You see how that's handed? So there's no risk of the roving assistant touching the hand of the operator. And this should be checked to make sure the saline's flowing before you start the procedure. I just wonder, Tejas, if you could find some tubing like this, which is sterilizable. It's so much more convenient to use than the wide bore aspirator tubing.
Yes.
Yeah, that's true. If we can get hold of less expensive kind of these tubings, it would be good to use.
I can give you a contact for this, Dr. Ardo.
Please, please, please. It should be really flexible like this. This is so useful and beautiful.
If you're doing a sinus graft and there's a lot of water spray, saline spray, then if you have one of these tubes as well, that's also aspirating the saline out, as well as the aspirator that the assistant is holding.
Yes.
Have you been bending these successfully, Ashwin?
Yes, sir. Not very often, sometimes.
I would have thought you'd done that 2 or 3 times a day.
But the tip quality is not so great, sir. But when it bends, it makes a sharp bend. Doesn't make a smooth curvature like this.
Hmm. So when you bend these, it needs to go along the floor, not just directly down onto the lower board of the, it needs to be shaped like that.
Can you go one slide back? I want to see the saliva, like the suction, the tube.
This one? Sidey? Can you unmute, Sidey?
Oh, there's some internet issue. I can't see. It's okay, carry on. I'll check it later.
Tell me when you can see it.
I can see the bend suction now.
Is that what you wanted to look at?
No, the tubing, suction tubing. One more slide back. Yes.
Okay.
Done.
Ashwin, I'm just about to show the bending of the See, that's a little bit too long. So we can make it a little bit shorter.
Please keep it there. Yeah, just a second. Previous slide. Okay.
Okay. Have you seen this video before, Elder?
No, I've not seen this.
Oh shit. Let me do it
I
again.
never knew that it's it's on the lingual side that you keep it. I always bend it and keep it on the from the buccal side, and I always used to wonder how it worked. Now only I realized how it works this way. Yeah.
That's where the saliva is.
Yeah.
No, the saliva is not in the buccal fold, it's in under the tongue.
What about the parotid saliva?
That goes down to the lower floor. That's I mean, the tip is near the back of the mouth anyway.
I'm trying this tomorrow.
What do you do with the salivary tube?
My assistant holds it.
What?
As long as she keeps it out of my sight, my line of sight, she's okay. Otherwise, I
So you have a three-handed, you do three-handed dentistry.
yes.
What's the patient doing while she's holding the saliva ejector?
Being pampered. Nothing. So the patient holds this.
I've had a patient hold these things for 40 years. I've never had an assistant hold them, ever.
Okay. I think tomorrow I'll try this.
Me too.
You've never told me this.
Can you share this PowerPoint?
Sorry?
Can you share this PowerPoint after this session? This presentation on bending the ejector.
You check your emails.
I haven't checked my email.
See, look at that.
The thing is on constantly. What it hurt is tissue.
No. It has to be bent. It mustn't go down like that. It must be bent so it's along the floor.
When the patient move the suction, do they move it? Or do they hold it steadily?
Just 1 second. What did you say, Sally?
Do they hold it steadily? Don't they move with the suction?
No, most of them are okay on it. I wouldn't have dreamed of having working with a one-handed assistant.
So while doing implantology, this plastic salivary ejector is just hung onto the patient's floor of the mouth, like how you showed, and the patient is not going to hold it.
No, you'd pin it to the gown, to the drape.
Okay.
Your patient could hold it because they're not sedated. So using that narrow tube compared with the big tube there is so much easier. Now, Eldo, when your assistant sets this up like this, does she check to make sure that it reaches the mouth okay?
Okay.
Now, I'm just checking to see if it's pulled through enough. Okay, do you see that? If you don't do this, when you come to aspirate, it pulls on the drape. You know what I mean by that, Eldo?
Yes, yes, yes.
Yeah.
Yeah.
As I've said before, when I'm teaching a group of different ages, the older people are going, yes, I know the problem. Oh, yes. And the young people are saying, stupid old fools, I'll never ever do that. Then reality strikes them later on.
Correct.
You are serious that in India, this sort of foil is too expensive?
Not at all.
What?
Not at all.
This is not expensive.
No, this is tin foil for food.
It's the only successful way of covering the light handles.
Yes.
When you've used this and your head has touched it, you could hear it, then you know that's contaminated. I showed you this bit here before. Can you see this? You can see implant placement part 1, can you?
Yes.
Yep, okay. Now, if you watch this, Aldo, and see how close you are to getting to this stage. Okay, I'm sure you've improved considerably. We'll see how it goes. Now you notice then the importance of when she put that drill into the handpiece, she pulled on it and it was loose. So she put it back in again. So once they put it in and they've closed the latch, they need to pull on it. Otherwise, you can have a drill dropping into the patient's mouth, which is frightening. Can I just explain something to you? These videos were taken 6 or 7 years after I last treated a patient. And it's 6 or 7 years after Christine had assisted me last. And the person assisting me is my accountant friend who is not anything to do with dentistry. So that's the background of these videos. That's why when you see Christine passing this handpiece to me, it's a little bit forceful. She wouldn't be doing it if she was practiced. She wouldn't be doing it quite so firmly. Okay, that should be a bit more delicate. Then she changes the drill. I would not dream of changing the drills myself. I wouldn't expect my hand to go more than about a foot away from the patient's head while I'm working. To see her little finger ready to take the previous instrument. Now this is a video of implant placement with drilling. This is the needleless injection for numbing the palate. Even under a sedated patient, I wanted to be as painless as possible. I've seen people ram local anesthetics in to a sedated patient who squirms in the chair. The fact that they can't remember it afterwards, I think it's still traumatic. I just can't do it myself. And the electronic machines for putting local anesthetics in were faster than the way I put it in. Now I'm rolling up gauze. I'm putting that at the back of the mouth with the longest part away from where we're going to work. This is the tongue guard. This is the gag. That's for the assistant to retract. And this is for me to retract.
Why did you put a tongue guard? Because you are putting that big retractor. Since you're doing on the upper arch, why should you put a tongue guard in the lower?
Keep the tongue out of the way. Sometimes the tongue gets in the way in the upper.
Okay, but that is just hanging there.
Just 1 second. You might not need to, although we did it routinely most of the time.
No, my question is only because you have put that mouth opener, that tongue guard is lying there. Otherwise, patient might.
It's keeping the tongue out of the way, because sometimes in the upper, the tongue does get in the way. Okay. You see, again, if the patient's sedated, it's less of a trial to them having that gag in there and everything else, okay?
Yes.
Eldo, you might sometime, have you got a video camera or a camera with a video ability to take videos? And a tripod?
Yes. You can try it on mobile even.
Okay. Sometime in the next month, video yourself doing an implant, okay?
Okay.
And from the setting up onwards,
Yes.
it would be very interesting for us all to watch it, and for you to criticize it and us to criticize it.
Yes.
Okay.
Yeah.
Because I'm sure you're aware, Aldo, that it's just as easy to do it right as it is not to do it right.
Yeah.
You know, the more right you do things, the more pleasure there is at the end of it.
Yes.
Okay. So now I'm putting the implant in with drilling and malicing. Local anesthetic's already in. Now, the question of who should mallet, when you're starting off in a thin ridge, you may want to do the malleting yourself. Okay, but then your assistant can take over. If you have a very skilled assistant who's experienced, they could probably do it right from the beginning. Okay. Because you want to be considering the positioning of the expansion instrument, and you're also holding the ridge to stop it splitting. You see, Anand didn't necessarily expect to be doing this sort of thing, but when he gets into his own practice and he realizes that you can't spend all your time doing prosthodontics because there's not enough work to do, you'll be doing everything else as well. You see, this patient, if we just talk about India, would be bone grafted, and then 6 months later would have the implants put in. Because the Indian dentist doesn't want to spend the money on the expansion instruments. So, in fact, it's good economically for the Indian dentist because he makes money out of grafting. The manufacturers of the graft material make money, and the person who loses out is the patient. Now, I've opened up the ridge sufficiently that I can now put in a drill without taking any of the crest of the ridge away. I'm now doing a little bit more expanding. And then when I use the next drill, it's going to go into the opening of the socket without taking any of the bone away. You see, Aldo, if you're not doing much expansion, I would still think that you put your pilot drill in.
Yes.
And then you do a little pushing of the first round expansion instrument in, just to open the socket up a bit.
Okay.
And then you put your next drill in and your next instrument. And when you put the instrument in, you put it in and you move it round a little bit. Okay. A little bit like this.
Okay.
To open up the socket. So I would always have the expansion instruments there to use.
Okay, and then use it progressively, or you jump into the next, you jump one.
Just 1 second. Abby.
Does anyone use Densaber?
I've used.
I have a duplicate of that.
How do you find?
Even if you're using the denser burr, I would use the expansion instruments to open up the socket. The videos of using the denser drills are appalling. The amount of crest of the ridge that they cut away if they started off with a pilot drill, put in a round expansion instrument and opened up the socket a bit, and then use the next Densibur, that would be much more sensible. Okay.
Okay.
Just tell me if Abby wants to come in, okay?
Hi everyone.
Hi.
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 So
All the sounds.
Elder, what am I doing at the moment?
What about?
What am I doing at the moment?
You're writing it down.
Sorry?
You are noting it down.
Doing what?
Noting down about Densibur and.
No, sorry. In the screen, on the screen, what am I doing?
Oh, on the screen.
I'll go back a little bit.
Yeah.
Okay, Christine's getting the implant ready, okay?
Okay.
Damn it. What did she just pass me?
What did she just pass you? That's what you said?
Yep. Watch. Okay,
Yes.
she's got the implant in the handpiece. What did she just pass me? What's the last thing you do before you put the implant in?
And yes, to take the bone that has come out of the osteotomy and to clear that region.
You're probing the
Taking
socket.
any soft.
She passed a probe to check the socket.
Okay.
Once you've got the socket prepared, do you check the site with the probe?
Site with a probe. Yes, at times. If I'm not sure whether the buccal plate is gone, then I use a probe to see.
And how do you do that if you don't know? How do you guess whether its buccal plate's gone or not?
When you hold your thumb and forefinger on both sides, then you'll be able to see the vibrations, the fermitas.
Eldo, your assistant should not allow you to put the implant in until you check the socket with a probe.
Okay.
Okay, I'll send you that every single time. I would hope that Christine would not pass me the implant until I check the socket.
Okay.
Checking the end of the socket to see if I've gone into the nose.
Okay.
Checking measly, distally, and buccally.
Okay.
So Abby is joining.
I think checking the socket is gold. I just learned something that's priceless.
Okay. I've just made a note. Checking the socket presentation to Eldo. I think I'm going to send it to everybody.
Yes, please.
Okay. If you could imagine, Tejas, a periodontal probe that you've straightened. Okay.
Okay.
So that it's the active length is twice the length of a periodontal probe.
Will it not snap? Like if I try to bend it out?
No, I've done it. I've done it many times. Okay. And you put it in. I'm just putting it in now. If you just watch it now. Now what I'm doing is I'm going up to the end very carefully to see if there's bone at the end of the socket or tissue or space. Okay. If there's bone there, that's good news. If there's tissue there, which is the floor of the nose, that's fine too. If there's air there, that's just a little bit of a worry. What you then do is you put some graft material, you put some membrane up there and a little bit of graft material and put it in a shorter implant. Okay. So you check the end, you check mesially, distally, palatally, and buccally to make sure that the socket is intact. Okay. Now, Eldo, I think we've talked about this before. I very rarely raise flaps.
Yes.
Because if the buccal plate is slightly broken, you've got the periosteum still supplying blood to those fractured little bits. Whereas if you've reflected the flap back, you're committed to using graft material. Okay. So I'm checking the socket. Once I'm happy with the socket, she's then handing me the Now, Tejas, do you use a handpiece to put the implant in?
No, I ratcheted by hand.
Ah! Okay. Now,
That's the most hated thing that, I stopped doing unitary implants just because of that. And I didn't, because some of them, you have to rash it first with the hand, and then you take away the adapter, and then, what is that? It's not called as adapter, something, the holder that you push it in, and
yeah.
it's big.
Tejas, if you put them in by hand, they go in like this.
Okay.
Before you ratchet. If you put them in with a handpiece, they go in like this. And then when the motor is getting a little bit struggling, you then stop and then you use the ratchet.
All right.
Okay.
Okay.
I used to do that by hand, but it's when you do it with a handpiece, it goes in 30 revs per minute. Okay. It goes in so much more smoothly. Now, the next question is, Do you routinely have gauze to protect the airway? Eldo does on Monday and Tuesday and on Saturday.
I started using it routinely after my patient swallowed a crown.
Yes.
Oh,
So even I do it routinely.
You put gauze in.
Yes, sir.
Good. Well done.
Yes.
yeah, Abby.
My dental assistants would not allow me to put a crown or a temporary crown or any small object into the patient's mouth without putting gauze in. They would routinely stick it in there. Okay.
Do you all buy those pre-cut gauze or
Or no,
Cut it.
sorry?
It's cut it.
the big roll, and then there's a technique of
Yes.
folding it so that the threads don't get exposed. I'll share that video with you.
Yeah, please do, that will be helpful. Yeah.
Yeah, you can sort out the CBs from the non-CBs on how they prepare their gauze.
No, mute. So
I have
nobody
an
heard
assistant who does that. So.
Do you understand that, Abby?
I
anything.
did.
That's a,
I
she
did.
didn't. Nobody heard anything.
Okay.
I
Next
did,
topic.
sir.
The CBs, you can sort out who are the CBs and who are
Okay.
the not CBs, okay?
Okay. Okay.
You understand that, do you, Anand?
Yes, sir.
Good, okay.
Yes, and CB means a clever boy.
Ah! Cheap bastards. Oh, Eldo, are you saying then that tin foil is not expensive in India?
It's not expensive. I've never told you that. I never told you that it's expensive.
I told you
Yes.
that. It is expensive.
Yeah. They just told, but still it is expensive. I mean, when we use it is expensive. We
You're
use
charging your
cling
patients
wraps
for that.
for our chair handles and all.
Yeah, you don't need to use it regularly for all routine work. You make plastic sleeves. But for implant cases, definitely.
Yeah, you can use. Yeah.
Ashwin, would you do me a favor? Write a post-it that you go and find out how much the tin foil is and how many fractions of a rupee per light it would cost.
I'll get a aluminium foil. Just a second. I'll tell you the cost right now.
Yeah. Please. That is great.
You see, it's too expensive to use as a dental practice, but it's perfectly okay to use it in Abby's household.
So this is 25 meter costing 180 rupees. Yeah.
How much is 25 meters?
25 meters would
How
be
many inches do you use, Stuart, per application? There was
Oh.
something on a slide, some 50 centimeters, something.
Something like that, yes.
That's half a meter, Abby, per use.
So how much is that, Abby? Tejas, if you look at the packs that we use, the bags, in the assistant side bag list, it's got the dimensions of the tin foil.
Okay.
Okay. Let us know when you worked it out, Abby.
okay, sir. 984 inches, sir. 25 meters, 984 inches. That would
Okay,
be,
that's sorted. That's 5 rupees a meter.
yeah. So like, correct.
So you use, I think for one case you spend 5 rupees.
That's a bit worrying, isn't it?
Absolutely terrifying.
Yes. And
I'm gonna go bankrupt.
do you have tinfoil in your apartment, Tejas?
Yes, I do. It's my kitchen.
Oh dear. And how much, if you cover a tray that you're going to put into the kitchen, into the oven, in order that the tray doesn't get oil and stuff on it, what does that cost you? That cost you
We don't
three.
eat food that night.
Do we sterilize these pieces of foils that we use?
What do you think?
Yes.
Ashwin, we'll forgive you for that question. In the setup list.
Oh yes, I remember saying yeah.
Okay, it's in that setup list, the assistant side bags items, okay? You see, one of the problems is that when you're learning, there's so much information. I mean, we're looking through that video of me putting an implant with drilling and then malleting. There is so much information there that you can't, the first time you watch it, see things. Now, Eldo's seen that video before, haven't you, Eldo?
Yes.
But you didn't notice about checking the socket with a probe.
No, I didn't notice that yet.
Okay, now, we ought to go back over the instruments required for implantology.
Yes.
And then you would see all these different things, okay, which you didn't see before.
No, I do this when I do a immediate extraction implantation. In that presentation, you have always shown that, you have to check all the sites. I do that routinely, but for routine dentistry, for routine implantology, I never used to do. Or if I'm very near to the sinus, then I used to poke it, near the wall, near the sinus floor. Otherwise, I never used to do.
Right, you'll be getting some videos, some presentations to look at, Ilda. Okay, so.
So it's 5 minutes to 10:30.
Right, let's just finish this presentation, okay, without too much interruption, okay?
Yeah.
So if you can work like this, you're doing pretty well. And we'll, Eldo will send me his video and I'll speed it up like this and you can see.
Thanks for bringing that question up about that probing before implantology, before placing implants.
You see, I'll tell you a problem that I have in teaching is because I'm so familiar with all this, I have a sort of suspicion that you all have seen all this before and you're sitting there bored stiff. But then Sally asked me a question, then Eldo asked a question, then Teja asked a question, and I realized that it's different for you because it's relatively new.
He just wants to join.
Oh. Okay. Now, the next time I've got some videos of a friend of mine that I taught in Kuala Lumpur. And you can see him doing some implant work at the beginning of the 2 days that we taught him. And then after 2 days, and you see the difference in how better organized he was. Okay. Okay. We've done a little bit better today in starting reasonably on time. I'm suggesting that we spend from 8 o'clock to 8:30 with some sort of discussion. And then when everybody's there, we can get on with the main thing. Okay. I just feel slightly disappointed when somebody misses out on the main things that we're doing, okay? Okay, what am I going to do now, Tejas?
You're going to visit Singapore.
Absolutely.
By the way, where are you?
I'm at Errol's brother's house in London. It's my friend Metin's birthday party tomorrow,
Wow.
which I'm going to, and he doesn't know I'm going to be there. So that's going to be fun.
Okay, that's great.
So I'm actually going to have a beer now.
Yours.
What about you, Tejas?
I'm pretty good. I'm good. I'm gonna go hit the sack now.
You are.
Yeah.
When I taught in Hyderabad, there was one thing that Tejas wanted me to bring him. What do you think it was, Elder?
I don't know.
Pure water.
What was it, Tejas?
Glenmorangie.
Glenmorangie whiskey. Yeah. I was just tell you one little story. When I go and visit people's houses, I never know.
Pause recording.
Sorry? Oh.
Please stop the recording.
No, I'll edit it out, okay? When I go and stay with people, I never know quite what their attitude towards various things is concerned. In America, sometimes they hold hands and pray before eating and all those sort of things, you know. And I never know quite whether they have alcohol in the house or not in the house. And my friend Metin and I were driving along the coast in California, in Oregon, the Pacific coast. And we went to this house at about 7 o'clock in the evening where we were going to stay the night. And it was right in the woods on the cliffs, looking over the Pacific Ocean. And we got there and it was dark. We got to the house and the lights were on, but there was nobody there. We sort of looked through all the windows, couldn't find anybody. So we started walking around and we eventually found these people. They were walking in the woods. And we went back to the house, we entered the kitchen and we were standing there and the host man said, "What sort of beer would you like?" So we suddenly realized we were in the right place. Oh dear. Oh God. Okay, I'll edit that one out. Over and out. We'll see you next week. Okay, I'll be back in my own place next week, hopefully. Okay, cheers then, everybody.
Bye, sir. Thank you so
Nice
much.
speaking.
Bye, all.
Good night,
Cheers.
everyone.
Bye.
Bye.
Stuart.
Bye.